Okay, so it is 7 o'clock right now. So I wanted to give everybody a couple of minutes to get logged in. I think some people are still kind of trickling in, but we want to go ahead and get started so we don't take up too much of your evening. A couple of announcements to get started. I am Lindsay McDaniel, one of the glaucoma and cataract specialists at Boyce Eye Center. I started here about 2 years ago, almost 2 years ago. And it has been such a privilege to work with this group of people. And we are continuing to expand over time. So we had some exciting announcements to announce to everybody here at the beginning. A lot of you knew Dr. Abraham Park, who was with us before my time, actually. He was here for a couple of years before I started, and then he left to move closer to family. So his wife's family lived out near LA, and so they moved out there to be a little bit closer, which I think worked out great with the pandemic and not being able to travel and things like that. He is actually coming back to Kansas City and rejoining our practice, and we are thrilled to have him. I know a lot of patients have missed him, and we are so excited to have some more glaucoma help. So he will be joining us later in July of this summer, and we are super excited about that. Another very exciting announcement is our practice is continuing to grow to try to serve more patients and more practices and be available however we can for you guys. And so we are opening another office. I think this will be, I know we've done a lot of expanding recently, and we're hoping to grow within these locations moving forward. But we are super excited to announce that we are opening a Prairie Village location this June. So a lot of exciting things happening this summer. So the office will be in Prairie Village near the Prairie Village shops, right off of 73rd and Mission. And so we will be getting information out to everybody so you guys know the details and who will be there. I will be spending some time doing cataracts and glaucoma. Dr. Kim will be out there doing cornea and cataracts, and Dr. Chappell will be out there helping us do plastics. So that's our plan for right now. And with the addition of Dr. Park, we are excited to be able to serve a broader location of people. So if anyone has any questions about those, feel free to let us know, but we'll be sending some information out your way, but wanted to give you guys that first announcement before we got started. So we have two very exciting topics for you. Glaucoma for the first one. So I hope by saying words, people don't automatically turn the snooze on. I know that's not the most exciting topic for a lot of people. But I wanted to kind of dive into where we are today. Things are changing so fast, especially in the world of glaucoma. So just kind of touch base on new things that are out, new opportunities, new options, what's changing, what's working, where we're going, and kind of why. And so just wanted to hit some of those things. So I got done with it and I was like, I hope I didn't put too much information in there, because I realized I spend more time with glaucoma than most. So bear with me if it is, but ask questions if you have any. And then Dr. Boyce is going to broaden our horizon on the cornea world. So we are super excited to hear from her, and we'll do that here in just a bit. So hopefully these extra couple minutes has given everybody time to log in. If there's any questions or anything like that, let me know. I am not the most familiar with Zoom. And so I know that there is a way to ask questions. So maybe some of our Boyce Eye Center people, if you guys see any questions, flag me. If I don't happen to notice it, or if anything pops up, just let me know. Because I tend to kind of get in the zone and just keep going. So my topic again today was managing MIGs. So I kind of want to just touch on the basics of kind of when patients are referred to us, how we handle those, what are our initial thoughts for treatment. You guys play a huge role in that because we get a lot of referrals from you guys, and kind of what expectations to set for those patients, conversations that you guys can be having with them, just knowing the different options that are available, and kind of why we make those decisions, I feel like can help to lead those conversations that you're having in clinic as well, in seeing what might be most beneficial for them. And then again, setting that expectation for what we'll have to say once they get to our clinic. So I guess I have to use this. Okay. So today, we're going to discuss I'm going to see, I'm sorry, bear with me, guys. Okay. Discuss the current and new options for initial glaucoma treatment. Discuss understand the types of MIGs that are currently available to patients. Understand the advantages and disadvantages of each of those and kind of why we move towards certain ones, why we're using certain ones, why you see more of certain ones than others. And then discuss the appropriate patient selection for pre and post-op considerations of these different types of things. So and we're so thankful that we are able to co-manage with a lot of you guys. We do see a lot of patients, and it is so helpful that you guys are able to see some of those post-ops for us. And so just knowing what to expect once they come back to you, I think is great as well. As background, as we all know, glaucoma is a progressive optic neuropathy. It's a leading cause of irreversible yet often preventable blindness worldwide. And I can't see my full screen, so I'm going to minimize that. So if anyone has questions or anything pops up, just let me know. It is the leading cause of irreversible yet often preventable blindness worldwide. Note I say often and not always, because as we know, sometimes we have the best pressures and the best control, and we're still unable to completely stop the progression. So that's always our goal. That's always an expectation that I set for patients, that this is a lifelong condition. There is no cure for this, and this is something that we're always going to be treating and monitoring and following. So I kind of set that expectation so they know they're in for the long haul here. Progression of the nerve damage is often slowed by reducing the intraocular pressure, either by decreasing the aqueous production or increasing the outflow. We can do this by the trabecular or uveoscleral tracts. And I'll show a picture here. So we've got medications, lasers, MIGs, incisional surgeries, or cycloablative procedures. So here's a fairly basic diagram. As we all know, the aqueous humor is produced by the non-pigmented epithelium of the ciliary body, comes through to the front of the eye, and then mostly is drained through the trabecular outflow. So here's where we see most of that resistance. So the increase in intraocular pressure is largely related to the increase in the resistance, which is largely found here. And then also from the uveoscleral outflow. So we have different medications and different treatment options that affect those different pathways. So I thought I would start with, if you guys had open angle glaucoma and someone told you needed to be on drops, what would your thoughts be? It's hard to do that on Zoom because I realize we're kind of talking to ourselves here. But if someone said you need to be on drops, they're benign, right? This is a picture from a plastics rotation I did in med school with Dr. Couch at WashU. Saw a lot of the toxic effects of these different types of medications. So this was a pretty severe prostaglandin orbitopathy with significant meibomian gland dysfunction. We see lid erythema, fat atrophy, and a chronic right upper lid chalazion, so not necessarily benign. Here's another photo. We've all seen this patient coming into clinic on 5 classes of medications, absolutely miserable. Is there something else we can do? This is a little granulated, but this is certainly job security for Dr. Boyce. But a lot of these medications have very, very toxic effects on the cornea. So we see pretty diffuse PEE here. This one almost looks like a dendrite, but it's supposed to be from the prostaglandin toxic keratopathy. So certainly not benign. What if I told you you needed a trab? Trabs, again, just like these medications, absolutely have a purpose, absolutely have a time, absolutely have a place. Does everybody need a trab? Probably not. Are there significant risks? Absolutely. So we can see these ischemic avascular blebs, see bleb leak, blebitis, all sorts of things. So I don't think any of us would be super excited about that. And those are things that I like to think about when I'm proposing these options to patients. What if I told you needed a tube? We see tube erosion, plate erosion. We can see infections because of that. So again, not benign, but again, they do have their place. So would you feel like this? I think a lot of us would, and a lot of patients feel like this after battling glaucoma. We can see here he's got a hyperencapsulated infranasal tube, which is causing some strabismus. And overall, just not super thrilled as it appears. So the intervention changes our threshold to intervene is kind of the point here. So procedures that are less risky, but more effective, we're going to do more commonly. So they have a higher intervention rate. Things that are less risky, but also less effective, we do them, but less often because we want that risk benefit profile to make sense. And conversely is true. If we increase the risk, also increases the efficacy oftentimes, such as tubes and trabs. So these are giving us our lowest pressures when we certainly need them, but we oftentimes hold on to those, keep those in our back pocket for when we really don't have another option. Again, we want that cost benefit profile to make sense. Unfortunately, by the time we say, yeah, I guess this does make sense, this is our last option, those are also the super high risk patients who oftentimes may not do great with these high risk procedures. So I tried to make a little chart of how do we manage glaucoma. There's been so much research and so many things that have come out over the past several years. We have so many more options. So I tried to make sense of that a little bit. So historically, we have hung out more on the left side because these were our only options 10, 20, 30 years ago. We didn't have all of these options. And so we kind of hung out on the medication side. We maximize those drops as much as we can, control as much as we can, kind of wait until there's 3 ganglion cells left, and then throw a Hail Mary trab. But why? That's all we had at that point. But not everybody needs that sledgehammer. And we have all of these other options. So in this day and age, when we have all of these things that are available to us, we should be utilizing these other things, such as the laser, such as other medications, such as the MIGS surgeries and different lower risk procedures to try to prevent these high risk procedures or having to be on all these meds for so long. So what drives our surgical decision making? A lot of different things drive that. When it's a mild glaucoma, we're looking to stop progression. Once we get into moderate and severe, we're trying to hold on to the vision. So when patients come into my clinic, I tell them we look at all sorts of different things. When we're talking about glaucoma, we look at the pressure, we look at how that's affecting the nerve in the back of the eye, and we look at how that affects the visual field. So when we're mild, we have a little bit more room to play with. So we don't need quite as low of pressures oftentimes. And usually that target goal will present itself on where we're seeing progression. But we have more options available to us. We can use moderate medications. We can do laser trabeculoplasty. We can consider MIGS. Once we're getting into more severe, we still have those options available to us, but we're thinking we need a lower pressure, we have lower targets, different goals. So again, I'll kind of refer back to this several times and just kind of go across. We won't go in depth into every single one of these, but I just wanted some name recognition of these are the different things that are available. So when we see those, or you see that a patient has had that, everyone's kind of aware of what they had and why. So first, talking about medications, historically, again, we have used drops. There's been 5 classes of medications. Those have been expanded, I guess, recently to 5, has been 4 for a long time. And then with the addition of Repressa, that's given us kind of a 5th class to play around with. And medications are certainly useful. We certainly need those. We're never going to get away from those, but I think drug delivery is becoming certainly a hot topic of glaucoma and possibly a wave of where we're going in the future. So glaucoma meds, I feel like, is typically first line, is typically the first thing that's offered, and oftentimes what patients would choose when you give them those options. So I kind of wanted to throw a couple of different ways of having that conversation with patients. So we have 3 treatment options. So this is kind of the first conversation you can have with the patient. We've got 3 different options. We've got meds, we've got lasers, or we can do surgery in the operating room. Why don't we just try this drop? It's once at bedtime. Sometimes it makes your eyelashes grow. We'll see you in 6 weeks. Sounds super benign. I think most people think of that conversation when we're in clinic and everyone's busy and we don't have a ton of time to discuss those other options. It sounds like the optimal option. It sounds easy. It doesn't sound like it requires a ton from them. And procedures oftentimes are scary for people. And so they typically gear towards wanting that medication. If we phrase that in a slightly different way, or a very different way, said, hey, we have 3 treatment options, same treatment options. Meds are typically our first line, despite studies showing that lasers and medications can be equally effective in some patients, and we'll talk about that data. Eye drops do have potential side effects. They can cause breathing problems, heart failure, depression. Some can blur your vision, oftentimes sting, so they can leave a bad taste in your mouth. They make you sleepy, maybe even thirsty. Fortunately, if that's not for you, we do have other eye drops that don't appear to affect the rest of your body. However, they can change the color of your eyes, cause the skin around your eyes to get darker, cause them to look sunken in, and make your eyes beat red. Also, you'll have to use them every day, oftentimes twice a day. You may need to take them more than one type, multiple times per day. And your insurance only sometimes likes to cover them, so it may cost several $100s per month. So I think if we really went into that and really thought about those different points of things that we see in our clinics every day, I think we would be more excited about other options. That being said, like we mentioned, glaucoma meds are oftentimes our first line. They oftentimes are very effective. But what if we could utilize these and get the same benefit of these medications with removing some of those cons that we had talked about? I'm certainly not sitting here saying that we're going to get away from these medications. I'm certainly not saying that we will ever completely get away from that. But what if we could get someone off of all 5 medications and get them down to 3? Or what if we could do something to relieve that cost burden, even just a little bit, I think would be beneficial. So something else that we tend to see in clinic, kind of along that line, is with glaucoma meds, I always worry about compliance. It's amazing how many people see me after not seeing anyone since Dr. Park, which was at least 2 years ago. They had a 90-day supply written for them. They have claimed to not see anyone else in the meantime, and they happened to just run out of their last drop this morning. So I always mention to them how lucky, like so thankful that it just happened to work out that you made this 90-day supply last for 3 years and happened to run out on the same day that you had this appointment with me. So super thankful for that. But I have to imagine that's not usually the case. I worry about systemic side effects. People have blood pressure issues, they've got asthma, they've got all sorts of other things And people come back all the time saying that they are super tired or just have different effects from these that I worry about. Contraindications, oftentimes with timolol, we love using timolol, but that does have some systemic contraindications that we worry about. For example, if they have hypotension or heart issues. With hypotension or lower blood pressure, we oftentimes decrease and do once daily in the morning, as opposed to the BID dosing that we would typically start. This tends to work, and people come back to the clinic and pressure looks great, and that's fantastic. However, if we really look at timolol ophthalmic, the peak effect is at 1 to 2 hours, and it should be relatively gone within 24 hours. So I always worry if we're doing it in the morning instead, worrying about their blood pressure. Yes, their pressure is amazing when they come to see you at 9 a.m., but what is it at 9 p.m.? And we'll never know that because no one's going to check their pressure at 9 p.m. And we don't have a way for them to check that at home. So I worry about that fluctuation as well. So it's great that the pressure is down, but if we have that fluctuation and that wave of pressure, what are we really doing? And then of course the ocular surface issues. We see so much dryness and people are really struggling with that. I know Dr. Boyce sees that a ton. And I'm very thankful for her because sometimes we're not able to pull people off medications. That is their only option, and their surface is just not great. So I think drug delivery is going to be a big topic in the coming years. It's already well underway. There is Durista. So this is the only one currently available. It's for the Metaprocess R. This is the biodegradable anterior segment implant. Travoprost XR with Envisia Therapeutics is currently in phase 2 clinical trials. Also a biodegradable anterior chamber implant. iDose with Glaukos is also in phase 2 clinical trials. This is a titanium implant that you implant into the trabecular meshwork, and it slowly eludes travoprost over time. Once it's done doing what it does, then it's removed and a new one can be replaced. Other things on the horizon, drug-eluting, misspelled there, drug-eluting punctal plugs, contact lenses, fornix rings or inserts, and nanofiber mats. So there's a ton of research being done. I think industry also sees that this is a huge potential market and are going into that as well. Durista, they have somewhat changed their campaign to Durista Now. I think they see all these other things also on the market and up and coming. And see that there's a big need for that. So Durista is currently the only one slow release implant on the market. This is available that we can use in clinic, and I do use this not infrequently in clinic. It's a prescription medication and drug delivery system for the eye for lowering the eye pressure in patients with open angle glaucoma or high ocular pressure. So ocular hypertension or glaucoma, which is great, gives us a broader indication of use. We use a 20 gauge needle on the inserter and implant the device. Most of the time I'll just do this at the slit lamp. It takes 5 or 10 seconds. So we put a little betadine in the eye, numb the dye. So first we numb the eye, put a little betadine in, do it right at the slit lamp. Typically I'll do one eye first and then have them come back in 1 to 2 weeks, make sure that we're seeing the effect that we had hoped for. As soon as we put it in, we stop their PGA. And the dose in this is so small since it's in the eye, it doesn't need to be large, but that really helps with the side effects that we see around. We don't see the periocular side effects. I'm not worried about allergic reactions. And it tends to work very well in people who respond well to the PGA, given the same active ingredient is used in both. And so this is great. It automatically doses for up to 15 months. I put a little asterisk there because that is what is on their website. It is, the FDA says this should work for about 4 months. I usually set that expectation as 4 to 6 months. After that, sometimes we will start seeing it creep up. About 25% of people were able to have effects even up to 2 years. But that's not the expectation I set for people. Usually 4 to 6 months seems to be good. The other issue is currently right now, it's only approved for one dose per eye. So I know a lot of people say, what's the point if I can only do this once? Why are we messing with it? We're gonna have to have the same conversation again in 4 months. And I hear that. We are actually part of the Triton study that is working to get the multiple approvals for this. And so in the near future, hopefully near future, but certainly in the future, this will be approved for more. That study is going on actively. Certain insurances will cover more than one, but I don't usually set that expectation for patients until we know that it would get covered. But even if we can't, even if we can only use it for the 4 months, and this gives someone 4 months, 6 months, or even longer of some sort of a drop holiday, I feel like that is certainly worth it. And so I think about that and I say, can we buy time until they're ready for cataract surgery? Is their pressure high, but they're just not quite ready, where we can do cataract surgery and MIGS at the same time? Can we give them a drop holiday so that we can treat their dryness, treat their surface, and then start back up with something, either something else or restart this, but just give them a little break? Are they having allergic reactions that we can treat that? Are they unable to use the drops at home? We have a lot of elderly patients who have RA, who have arthritis, who will straight up tell you they're not able to get it into their eye and they don't have anyone around to help. I think that's certainly beneficial. And then recently in COVID, when people weren't comfortable going out, if we can have them come in, and hopefully we're not having other waves of this in the future, but I think that was a great example of there are times when people just can't go out, and this can buy several months until they're comfortable or until there's a better time to get out of the house. So I think there is certainly a place for this. I think there is a big future for this. And I'm excited to see where this goes. But I do think that that's a great option and something that should be offered to patients as opposed to using the drops all day, every day. So I usually give them that option and let them decide. But a lot of people like the idea of not having to use a drop every single night. One of the other first line options that I mentioned for people is SLT. So recently some studies have been done that have the data is very strong. And so again, I like to present that as an option. So we can use drops, we can do the slow release implant that does the dosing for you, or we can do this laser. I tell people oftentimes they're going to need a combination of all of those things at some point. It's just, what are we ready for now? What do we think is best for you at this point? So all sorts of different lasers, again, more technology, things are emerging in that as well. But I like to offer SLT. We have great effects with that. And the data is very strong. Historically, the transscleral CPC was our only laser available, which is kind of a sledgehammer for that not all patients need. High risk, but high effect. Since then, we have all sorts of other different things that are very effective and much less risky. So with the lasers, they're minimally effective. They have a very minimal side effect profile. They have increasing effectiveness over time. I tell patients this is a very mild laser. So I set the expectation that they're going to stay on their medications. It's going to take 2 months for us to see the full effect. And then we go from there. We'll do a trial off of medications or a medication at that point, if we feel it's safe to do so. If we're not quite at that goal, it is a very safe laser. And if we have that time to wait and see, I think it's still a very valuable option. With SLT, it's a brief application of the laser energy, selectively targeting the pigmented cells within the trabecular meshwork, causes minimal tissue damage versus the historic ALT, which is, I think, rarely done at this point. You can repeat it. This can lead to decreased efficacy over time, but I often find if people do well with it the first time and have a good effect that lasts a reasonable duration of time, that they seem to do well with repeat procedures. This induces a biochemical and cellular change to restore the trabecular function and improve the aqueous drainage. So I tell people that this is a quick laser, takes 5 minutes or so on each side. and it helps to open up that natural drainage system within the eye. And that seems to make sense for a lot of people. With the expected results, I usually set the expectation to patients of my goal is about 20% or replacing one of the medications that they're on, or not starting the medication. Oftentimes we see significantly more than that, and it depends on the anatomy and exam, type of glaucoma, of course, severity, but we tend to see really good results with this. The expectation should be 19 to 29% reduction at the 12-month mark. They say it may take 6 weeks. I usually tell people 8 weeks because there are some people that come in and they just need a little bit more time. So I usually do 8 weeks, about 2 months afterwards, to see how they're responding. 60% of patients achieved a 20% reduction at 12 months or more with the SLT. Predictive factors for a successful outcome were older age, higher baseline IOP, using this as a primary therapy, as opposed to using this after multiple medications have been exhausted. So the LIGHT trial is a new-ish procedure of the past couple of years that was released. This looked, you can read that. 718 treatment naive patients with open angle glaucoma or ocular hypertension were randomized to drops or SLT. This looked at the quality of life, visual acuity, IOP at 3 years. And so if you were making this decision for yourself, what if I told you 74% of the SLT patients remained drop free at 3 years and had better IOP control at each visit and had less secondary surgery and had less disease progression? So we look at these numbers and the data is very supportive of doing SLT as a first-line therapy. So we have it available, it's quick, the risk profile is very low. It got our patients to a target within their target IOP, and importantly, it led to less disease progression and secondary surgery, which I think is huge. A subsequent outcome came out about the visual fields not long after that. I guess that was in April of 2020, but noted a greater proportion of eyes underwent moderate or fast total deviation progression on their visual field in the medical therapy group compared to the SLT group. So 26% versus 17%. A greater proportion of point-wise pattern deviation rates were categorized as moderate or fast in the medical therapy group, which concluded a slightly larger population of ocular hypertension and glaucoma patients treated with medical therapy first underwent rapid visual field progression compared to those treated with SLT. So if we can preserve our visual field, so more so than what that target pressure is, we find that target pressure to avoid progression. So if we're able to prevent more progression by doing SLT, again, I think that's beneficial. So why isn't this our first line? I think people, again, hear that this is a procedure. They think of a laser as something scary. And I think it's our job to kind of present that in a different way for them. We wonder, is it repeatable? Like we mentioned, if it was effective initially, the data shows it's typically effective with retreatment. That can vary over time, but we are able to do it again. What about in severe disease? There was a study that was done, I'm sure multiple, but once the glaucoma is severe, the trabecular meshwork is often damaged and the SLT may be less effective than other surgical options. So if someone is severe and on several medications and we just need a couple of points or something like that, I still think that it's a safe option, and I will oftentimes try it in these patients who don't want surgery, who have very fragile eyes, who we're trying to just get a couple extra points, but are overall okay with where they are. They're okay not being completely drop free. We're just trying to avoid a bigger surgery at that point. And sometimes we get great results, but oftentimes we're seeing resistance in other areas of the eyes. It's not just the trabecular meshwork, and the trabecular meshwork, by the time it's severe, oftentimes is very frail and they're scarring further back. So we may not see quite the outcomes, and I never expect to see quite the outcomes that I do if we were to use it initially or in more mild disease. Contraindications, this is where gonio becomes super important. So if they're very narrow, they have angle closure, if they have any PAS, don't do SLT. I have seen and read about if you do SLT where there's already PAS, you can zipper the rest of the angle close and kind of precipitate angle closure. Or a history of uveitis, you can encourage that inflammation within the eye. So if there's any history of that, I typically don't do it either. And then moving here, we're not going to discuss each of these. This is kind of our third option for therapy is glaucoma surgery. So the conventional outflow is through Schlemm's canal or angle surgery. There's all sorts of different things: canaloplasty, iStent, Hydrus, KDB, Omni, ABIC, GAT, trabectome, and newer on the market to be iAccess and Trabex. So industry sees the need. They also see kind of what else is going on. So we recently had some changes in reimbursement to where certain MIGs are reimbursing differently than others. And so a lot of industry is trying to get into the goniotomy market, which is why I think we will start to see all sorts of different names, but it's really all the same. A lot of people are trying to get into that space. But at the end of the day, you're removing the trabecular meshwork, regardless of what you call it. So here's another busy slide. This is just kind of saying the same thing in a different way, but shows that we have these different ways of targeting where that outflow is. So again, the Schlemm's canal is that angle surgery. There was a suprachoroidal or uveoscleral outflow. The side pass was the one that was there, caused endothelial dysfunction and was taken off the market. So we don't currently have something in that category. And then subconj, we've got Zen, Trab, and tubes at this point. So other things are being studied, but those are the three big ones in that category. We look at this gets very busy. The list that I just showed you, again, very busy. Sometimes it seems overwhelming, so many options. Where do you start? What do you do? I don't think this is a bad option or a bad problem to have. Again, historically, it was let's maximize drops, and then we can do a tube or cycloablation. And we just didn't have a great option in between. So if you're torn between two things and say, hey, micropulse laser might be beneficial, or we can try a KDB or other things with similar side effect profiles, I think that's a good option to have, a good problem to have, because that's telling us that we have a lot of different ways that we can go with this, which I think is good. So the MIGs have added a whole lot of tools to our tool belt. How do we decide which MIGs procedure or which glaucoma surgery is best for patients? So MIGS stands for minimally invasive or micro-invasive glaucoma surgery. And a lot of this depends on gonio, so on what we're seeing on goniotomy. If we see any PAS, so different devices are approved for different types of glaucoma. Each procedure has varying levels of efficacy and safety profiles, so we can kind of personalize that for what the patient's goals are, what our treatment goals are, how low we need that pressure to be, what we think their eyes can tolerate, essentially. So broadly speaking, MIGS is angle surgery or trabecular meshwork bypass. So I discuss with patients that we are trying to make their natural drainage system more effective. So we're working within their natural drainage system, trying to open that up to help the eye work a little bit more effectively. Again, 90% of our resistance comes from the trabecular meshwork. So excuse me, 90% of the resistance comes from the resistance within the trabecular meshwork. So if we can bypass that, that's oftentimes extremely effective. The different options that we have a micro stent, so we can stent the canal with different implants. We can do traditional trabeculotomy or disruption of the trabecular meshwork, either with goniotomy or GAT. GAT is just a goniotomy that's 360 degrees. We can do that with a blade or with a suture goniotomy. Omni is another device, and that's actually in both of them. So Omni is just a device to make this happen. So you can thread a catheter 180 degrees to facilitate that. That will do viscodilation, so kind of open up Schlemm's canal, and then you can also do goniotomy, depending on if you feel that's necessary. AVIC is the same as Omni, it just uses a catheter instead. And then with a goniotomy or removal of the trabecular meshwork, you can use trabectome, KDB, or the new I-axis or Trabex. But again, they're all doing the same thing. You're removing that point of resistance in the trabecular meshwork. The advantages of MIGS, it restores aqueous flow through the traditional outflow pathway. It bypasses the primary site of reduced aqueous outflow, has a very favorable safety profile. It should say low hypotony risk, nothing is impossible with glaucoma. And it's easily combined with phaco, and actually has to be in certain MIGS. The disadvantages, it gives us modest IOP reduction. You're never going to get low below the episcleral venous pressure with this. But most of the time when we're doing this, it's mild to moderate. And if we can get in the mid-teens or below 18, it's oftentimes okay for those patients. Efficacy is dependent on functionality of the distal outflow. So discuss that with patients. They say, hey, we're going to throw a stent in, we're going to do a glaucoma procedure, we're going to, whatever it is we're doing, we're going to try to enhance the functionality of your natural drainage system. Just like unclogging your drain or your shower drain or your sink drain, if we unclog what we can see, but the pipes further down are still clogged, it may not be as effective as we had hoped, and we may need to go back and do something else or discuss other options. Unfortunately, there is no way clinically or in the OR to see if anything further down, if those episcleral vessels or the aqueous veins are clogged or what's going on with those. It does require intraop gonioscopy, so you need a clear cornea, and there's certainly a learning curve with that. And it does require some patient cooperation intraop, so there's always the fun patients who just feel like they need to look at everything. They can't hold a gaze in a certain way, and that can make doing an angle procedure very dangerous. It can lead to iridodialysis or cyclodialysis, and is not fun. So patient selection, you want their IOP target to be in the mid-teens. You want them to be able to tolerate medications if they need to, if they're not quite at goal. If their surgical risk is high, this is a lower risk procedure that they are likely more able to tolerate. If they have difficult follow-up, then we can do these with, again, a good risk profile, and they don't need to follow up quite as much as with some of the bigger procedures. Oftentimes they need to be phakic for iStent or Hydrus. And then you want their distal outflow resistance to be low, or it just won't work. So in the first category, these are probably the ones that we see most often. So I think everyone is fairly familiar with the iStent and the Hydrus. So I put some photos on the bottom from them, and then what we see on gonioscopy. Advantage of the Hydrus and iStent: low risk, high efficacy, minimal tissue disruption. So it preserves tissue for if you need it later. This restores the outflow through the traditional pathway by bypassing the primary site of reduced aqueous outflow. Disadvantages: they are fairly expensive because you are leaving that stent or the device. You can do a goniotomy with a 27 gauge needle if you want. So you don't need a ton to do that. Here you do have this expensive stent that you have to worry about. It's only approved for mild to moderate open angle glaucoma, which excludes a lot of people. I wish it was approved for at least ocular hypertension, because those patients also, their pressure is too high, and that would lead to glaucoma in a lot of people if we left it that way. So I wish it was approved, but it's not. And then both of these stents have to be combined with phaco. And then again, it's dependent on the distal outflow pathway. The Horizon study is the largest MIGS trial with the longest follow-up. This compared the phaco Hydrus with phaco alone. And this looked at mild to moderate patients with mild to moderate glaucoma on 1 to 3 medications. The long-term outcomes looked at our patients medication-free at 60 months or 5 years. 66% of patients with the phacohydrous group. So they had about 80% follow-up through these 5 years. 66% in the phacohydrous group were medication-free, previously on 1 to 3 medications, whereas 46 in the phaco alone. So that's a fairly significant difference. And medication-free was defined as IOP less than 18 on no medications. If we specifically look at one medication patients, it was 73% compared to the 66, which include the 1 to 3 medications. Another key finding was a reduced risk of reoperation. And so only 2.5% of the hydrous patients required more surgery within those 5 years versus the 6.4 in the cataract surgery alone. So if we're trying to prevent further glaucoma procedures, this was about a 61% risk reduction, which is certainly significant. When we look at iStent compared to hydrous, this is why I do more hydrous than iStent. I think every surgeon has their preference based on what's best in their hands and what their personal outcomes are. These are more generic studies, but we did look at that when I was in training and looked at our own personal, and in my hands, it seemed to work. The data supported that. This study was done up in Canada by Ike Ahmed. And so this was standalone iStents versus hydrous, which we cannot do here in the States, but they are able to up there. So this looked at the iStent inject, which is 2 iStents versus the hydrous. Overall, the IOP lowering effect was very similar in both, if you can see on that first one. However, fewer meds. We were seeing fewer meds on hydrous versus the 2 stents, and the complete success, which was defined as no meds, no surgery, and IOP less than 18, was higher on hydrous. So that supported that, but again, both were helping with the pressure. So those are both certainly options. So why do we feel like we're seeing that when we look at iStent versus hydrous? The aqueous outflow through the trabecular meshwork is segmented. It's not uniform. It's divided into the high and low flow areas. The high flow areas typically have an aqueous vein nearby. So when we put the hydrous in, that spans about 90 degrees. So you're much more likely to catch one of those aqueous veins as opposed to the iStent, which only is very, very small. And so maybe a little bit harder to catch one of those aqueous veins. So that's one theory as to why that data was being seen. Again, different surgeries have, or different surgeons have different preferences and what's best in their hands. So what if the patient isn't mild to moderate, has any component of angle closure, is just ocular hypertension, is already pseudophakic, is not ready for cataract surgery, has severe glaucoma? There's a lot of patients that are missed out on the indications for iStent or hydrous, and I think it's important to consider them as well. So then we move into the trabeculotomy, viscodilation, canaloplasty, goniotomy category. And this is what is approved for those patients and is still an excellent option. Advantages to this, they are very versatile. You can use the goniotomy or the blade to help with angle closure. I oftentimes give patients an opportunity to fail this first. So if they're in angle closure, even if it's chronic angle closure, I've had several patients where you go and do goniotomy, so typically with cataract surgery, pull down the PAS that we're seeing, open up the angle, and have done great. The earlier you can do that to when the angle closes, the higher the success rate, but I like to give them a chance to fail that first before going back and doing a tube, just to preserve that real estate for if and when we need it. Disadvantages, there's a higher hyphema risk, and you do need to remove that trabecular meshwork ribbon because otherwise it can float back and just clog the trabecular or the Schlemm's canal again. There aren't a ton of long-term studies. And if you wanted to do the viscodilation, that the devices that help to achieve that are quite expensive. I've got a couple of graphs. I'll kind of run through those quickly. I know I'm running out of time here, but this just looked at the success rate of dual blade or KDB goniotomy in severe eyes, which I thought was significant. So this looked at, basically said, regardless of what the baseline IOP was, whether it was 20 or whether it was 13, we were getting overall pressures after the KDB at what the patient's EVP was, which I thought was interesting. So you're going to see more pressure reduction with higher starting pressures, but that's because you're really just getting that patient down to what their EVP. Okay, can you hear me now?
Yes.
Okay, I'm gonna keep going. I got it. Okay. And so this looked at the results, again, of severe glaucoma with KDB. 2/3 of patients reached their target IOP of around 15. And half of those patients were able to discontinue medications, which is significant, especially when these patients have severe glaucoma, have been on drops forever, and we're really following these closely. That's a very significant result in my opinion. This again just supports kind of how much of a goniotomy is necessary. And I saw a question. I have a couple more slides and then I'll get to that question, but I have not forgot it. We'll go to this here quick. So this is just a quick comparison. We've really talked about all of these things. This was in the handout that I had given you, but just kind of an overall advantages and disadvantages of the different types of the angle surgeries, and kind of why we use the different options. Reflex hyphema is probably the most common thing that we see or hear about, especially for a KDB and some MIGS procedures. I don't mind seeing this. I know a lot of people don't like to see this. Keeping the pressure at an IOP of about 25. So I do try to leave them a little bit higher at cataract surgery. Sometimes the stent seems to be working very well. It's hard to repressurize the eye, so we'll see a little bit more reflex heme. And then the 1 to 2 weeks post-op, we just elevate the head of the bed. No straining, bending, rubbing, shield at night. I always set that expectation that I expect things, a little bit of blood in the eye. I expect things to be a little bit blurry, so that they know that coming into it. I don't do any additional steroid or cycloplegics. I continue the anticoagulants. The risk of stopping that and the patient having a stroke is much higher than the risk of the bleeding. Most of these are resolved within 1 to 2 weeks, and rebleeds are very rare. Manage the steroids the same as the basic cataracts. I don't increase those again. And then if they have any steroid response, which they can have with MIGS, we typically see that at about 2 weeks. You can see that post-op until about 2 months after the last drop of the steroid. So if we are starting to see that, you can always taper more quickly or switch to Lotemax or FML. I typically like to keep their drops unless it's really low, but because of that possible steroid effect, I typically like to keep that on until we're done with the steroids, or at least that last post-op visit, and know that we haven't seen it increase, and then discontinue one class at a time so we know what effect each of those are having. Patient selection, I know we had kind of talked about that already, but once we've decided that the patient needs a surgery, its most important decision is whether or not we want a MIGS procedure versus a filtering procedure. We want to either naturalize their drainage system versus bypass it completely. So we want to know, what is their target IOP? What is the severity of their disease, rate of progression, life expectancy, symptoms, medication tolerance, all those things go into that. if they need a high teens versus low teens, and all those things go into what this patient can tolerate and which procedure would be best for them. And so what do I talk to my patients about? Again, with MIGS procedures, we talk about enhancing their natural drainage system, whether that's removing any scar tissue or just putting a stent in to keep it open. I always talk to them about a hyphema. I set that expectation for them, so that's what they're expecting, whether or not they have it or not. And then that there is the possibility of a further surgery or additional meds, but that option is certainly still open to us after that. Benefits, it's quicker, safer, better or quicker visual recovery than some of the more significant procedures. More predictable refractive outcomes. So I feel comfortable doing this with any of the different types of lenses when we're doing cataract surgery. Subconj surgery, we're creating that new drain, again, higher risk, but also the benefits or the IOP lowering seems to be more significant. This is kind of just a summary of the whole thing. We're kind of moving to the idea that glaucoma is an interventional condition, or an interventional disease. We should look at this as in a more proactive as opposed to reactive way, aim lower and aim earlier, so that we can use some of these safer options and try to prevent progression as opposed to chasing our tails and then kind of saving onto those few ganglion cells once we get really severe. So at the time of cataract surgery, I think that's a great opportunity to talk to them and use that as an opportunity to lower the pressure, at least give them that option. And then it's their decision whether or not they prefer to take that. So last time I talked to you guys was about 2 years ago. I just moved to Kansas City. I just started with Boyce Eye Center since then, last September. Marty and I went out to Colorado. We got married. We're in Kansas City and super happy to be here. So it's been a pleasure to work with all of you guys. If there's any other questions, I did get a message about the risk of CME in pseudophakic patients on a prostaglandin analog. And I'm not sure what that is referring to. Is that the risk of CME from cataract surgery? Is that what I'm seeing? Because they're on a prostaglandin analog? Is there? If there's a typing or in the chat, I will answer that.
Hey, Lindy.
Yeah.
This is Andy. Back in the dark ages, when dinosaurs roamed the earth, we used to try to take people off of prostaglandin analogs around the time of cataract surgery because we were afraid of them developing CME.
I see.
That's still a thing, or maybe we're past pterodactyls and
that is something that I have never heard of. So that has never been a fear that has been instilled in myself. So I would imagine we're past that. That's not something that I worry about. I keep patients on that. And I have never thought twice about it. I think there is that historic fear of CME from different things with the PGAs, but I've only loosely heard of that. I have not read anything about that. That's not in the current literature. So that's not something that I worry about. And I feel very comfortable keeping patients on that. And because of the once daily dosing, that's still my go-to. So
I'll just chime in briefly. I don't know if you can hear me, but that's been my experience as well, is that it's exceedingly rare. And usually somebody's developing CME on a prostaglandin, it's attributable to another cause. It's more common, like diabetes or such. And so it's not routine to stop prostaglandins anymore for cataract surgery. Same thing with herpetic eye disease, which was thought to be common with prostaglandins. That's not really true, as it's been more commonly used, not commonly seen anyhow.
correct. All right. Thanks, guys. I hope some of you are still awake to listen to Dr. Boyce talk about cross-linking.
Hello. Everyone hear me okay? Thank you for that great talk, Lindsay. and I am happy to be joining you all again this evening. It has also been about 2 years since I have gotten to chat with everyone. And hopefully in the fall, we will get to do this in person. We can all hope to see each other's faces again soon. So good evening. Thank you all for coming to join us. Please make sure, I have a note from Tammy that if you are logged in using only your first and last name, or excuse me, if you're logged in using only your first name, please also try to include your last name, or if not, make sure to check your chat box so that she can verify who you are so you get credit for being here. I also apologize in advance if at some point during my talk you hear me sneeze or wipe my nose. My 2.5-year-old continues to be a petri dish of joy for our household, and we are yet again just a little bit sick, but not sick enough to join you tonight. So hopefully you enjoy this talk tonight. I'm going to talk about collagen cross-linking and our experience with this, what we feel is very useful technology for our patients over the last 2.5 years. So again, we're discussing collagen cross-linking in reference to the Avedro, or now Glaukos unit, using the Dresden protocol. This is the protocol we offer our patients as it is the only FDA-approved protocol for treatment to stop progressive keratoconus and post-laser vision ectasia. This protocol was developed in the mid-90s at the University of Dresden, and the first ever human study was published in 2003. The USA trials began in 2012, and it was finally FDA approved in 2016. We offer this procedure by myself and also our newest cornea doctor, who I hope many of you have had the opportunity to work with over the past 8 months, Dr. Yang Kim. We are able to evaluate patients with the gold standard pentacam topography at all 3 of our current locations in Kansas City, Lee Summit, Missouri, as well as Lansing, Kansas. We've had the opportunity over the past 2.5 years to cross-link 115 eyes, and thankfully we have experienced no significant adverse events, and to our knowledge, none of our treated patients have progressed. As we all know, keratoconus is a serious and progressive eye disease with the usual onset in the 2nd decade of life that, if left untreated, can result in loss of vision, and in 1 in 5 patients will eventually require corneal transplant. The prevalence worldwide has historically been quoted to be 1 in 2,000. However, newer estimates are close to 1% due to better topography technologies and the ability to recognize early disease. This is a non-inflammatory, always bilateral, although can be very asymmetric corneal ectatic disease. Again, typical onset around puberty, with progression into the 3rd or 4th decade being usual. This disease causes progressive thinning and steepening of the cornea, leading to irregular astigmatism and myopia. There are known environmental and genetic associations of atopy, eye rubbing, floppy island syndrome, and also genetic associations with the condition running in families associated with Ehlers-Danlos syndrome, Marfan syndrome, and Down syndrome. Similarly, but different, post-laser vision ectasia is thought to be an exacerbation of a tendency towards keratoconus. We think these patients have preoperatively abnormally weak corneal stroma that is further weakened by the biomechanical thinning and shaping of the laser vision correction. The incidence is estimated to be about 1 in 1,000, but with better and better topography analysis and screening of patients prior to consideration for laser vision, we all hope that the incidence will continue to decline as these technologies flag at-risk patients. Early diagnosis for these patients is really critically important, as any progression often results in loss of vision, decreased tolerance to contact lenses that is caused by ongoing changes in the cornea. The earlier the diagnosis, the sooner treatment can be provided to stop or slow the progression. And so it's important to diagnose, educate, and refer for treatment before vision is lost. In the traditional treatment algorithm of keratoconus patients, they often progress rapidly from glasses to contacts to rigid lenses to scleral lenses, and eventually they would find their way to a cornea doctor when the disease was so advanced they needed surgical intervention. We now are really trying to avoid keratoplasty whenever possible, as many of these patients, as you know, can maintain excellent vision even in advanced disease and scleral lenses, and due to better treatment options and the long list of complications that come along with this very serious intervention, including but not limited to a 12 to 24-month postoperative recovery, complex astigmatism management, often still requiring a contact lens for best vision, long-term rejection risk, and therefore the need for long-term steroid eye drop use, which can lead to cataracts and glaucoma. Patients are at a lifetime increased risk of trauma to that eye as the wound never fully heals. And finally, it's predicted that 73% of these grafts may fail at 20 years and 98% fail by 30. Therefore, the updated treatment algorithm really focuses on identifying the signs and symptoms of keratoconus as early as possible, again, including myopia, astigmatism, inability to refract to 20/20 without a known cause, family history of keratoconus, eye rubbing, allergies, or a predisposing genetic condition. Once these are identified, it's really critical to get a topography, and if that's normal, referral to a corneal specialist for collagen cross-linking is indicated. And then following that, management of the refractive demands with their primary optometrist. This slide really highlights the importance of early diagnosis, as worsening of keratoconus severity has been associated with lower quality of life scores. They may be substantially reduced even with the better seeing eye has normal or near normal vision. The impact of keratoconus is outsized relative to the degree of visual loss, with greater negative impact on vision-related quality of life than retinal diseases such as wet AMD, retinal vein occlusions, and even diabetic macular edema. Again, therefore, strategies to prevent keratoconus from reaching severe stages are warranted to maintain quality of life. The goals of the updated treatment algorithm and cross-linking are highlighted in green: to reduce the risks of progression, avoid transplant, to find a potentially stabilizing and therefore more permanent solution for our patients. And cross-linking can also, in some cases, improve image quality and reduce refractive demands. We are currently not doing such a great job of diagnosing and treating patients as early as we should be, as indicated in this study from 2020, showing that only 13% of patients were diagnosed before age 18, even though we know onset is usually before that. By the time they had been diagnosed, 70% had reached a stage 2 topographical classification. We're going to go through a few cases now. So case 1 is a 28-year-old that was referred for worsening myopia and astigmatism, currently in contact lenses with no history of laser vision correction. The refraction in the right eye was -2 with 20/30 vision, and in the left eye, very asymmetric, -150, -5, and vision only corrects to 20/60. The slit lamp exam, however, was remarkable for a nasal pterygium in the left eye. Briefly reviewing what we're looking for on topography, as I tell the patients warm colors are steep, as you know, cold colors are flat. And we see a very obvious area of bright red inferior asymmetric steepening on the axial topography in the lower left box of both eyes. In the left eye, we see nasal flattening in that area of pterygium that's highlighted in bright blue. And if we look at the Kmax, it's significantly elevated in both eyes at 50 in the right eye and 53 in the left. If we look at the anterior and posterior floats at the top left and top right, respectively, there are areas of steepening that look yellow-orange, with correspondence to the thinnest area of the cornea with inferior and temporal displacement. This area is also much thinner than average at less than 500 microns in both eyes. This patient has classic frank keratoconus in both eyes. In case number 2, we see a 38-year-old physician who reports new onset doubling of the vision in his right eye only for the past 1 month. He was a prior emmetrope, had no history of laser vision correction, and his uncorrected acuity was now 20/70 in the right eye and still 20/20 in the left. Refraction really wasn't too impressive. Mild hyperope in both eyes, refracting to 20/20, and his slit lamp exam was unremarkable. But when we look at his keratometry readings, they're still in the normal range, 44.6 in the right, 42.8 in the left, but very concerning that they're 2 diopters steeper now in his symptomatic right eye. His symptoms and asymmetry prompted a topography evaluation, and this was even more concerning when we see a yellow-orange area of asymmetric inferior steepening at the bottom left corner axial map of both eyes. This constellation of findings was consistent with early keratoconus in the right eye that is likely progressive. The left eye will need to be monitored very closely as well. So the keys to this case are really to listen to your patient, and if you find no other reason for monocular diplopia, such as dry eye, cataract, retinal disease, you really need to think about the corneas. This is a third case in a 62-year-old with worsening vision in glasses over the last 5 years. She's now requiring soft contact lenses for her best vision. She has a history of LASIK in 2007. And in 2014, the refraction in her left eye was -125 plus 275, and she refracted to 2020. Fast forward to 2019, and she's now a -275 plus 4 and only refracts to 2030. Her LASIK flaps are totally clear, and she has equal trace to 1 plus NS in both eyes. When we compare her topography maps from 2014 on the left to 2019 on the right, unfortunately, there's very obvious progression. On the right, in 2014, the steep K was only 47.3, and it's now 50.2 in 2019. Her thinnest pachymetry was 399, and it's now 375. So this example really highlights a few points. The laser vision ectasia does not follow age cutoffs and can unfortunately pop up years after the treatment and continue to progress later in life. This also highlights why it's important to identify and treat these patients early. With her refraction in 2014, she was easily able to tolerate glasses, but as the condition has progressed, she's having more and more difficulty and now requires a contact lens for her best vision. Finally, case 4 is a 70-year-old with worsening vision in his right eye over the last 2 years. He's required contact lenses for his best corrected vision for many years with a known history of asymmetric keratoconus in the right eye worse than the left. His refraction in 2019 in the right eye was -4 plus 5, 2020, and now in 2022 is a -6 plus 6 at 2025. And so you do see in his refraction progressive myopia, progressive astigmatism, and decreased vision, concerning. He has apparent keratoconus on slit lamp exam without scarring. However, when you look at his lenses, he has a 2 plus milky NS on the right eye and only 1 plus on the left, and they were pretty asymmetric. In this scenario, it can be challenging, though, to determine what's causing the refractive shifting. Is this progression of keratoconus, or is this related to nuclear sclerosis, and how do we tell the difference? So in seeing patients like this, it's helpful to get a topography and a keratometry at their annual visits so that we have an apples to apples comparison to determine what the source of the refractive shift over time is. On review of the records, this patient happened to have both that showed stable measurements as compared to 2019. Additionally, that was reassuring, the patient had asymmetric cataract density on the right as compared to the left. We therefore determined that his refractive shifting was likely related to his cataract, and we elected to follow his pentacam measurements for him in a year to prepare for potential cataract surgery. With documentation of stability and somewhat regular astigmatism, these patients can get some improvement in spectacle vision with toric implants at the time of cataract surgery. If cross-linking is required, in a perfect world, we would try to wait about a year for corneal stabilization prior to proceeding. Let's talk about the red flags of keratoconus on evaluation that should really prompt further investigation with a topography. These include distortion of Myers on keratometry, error messages on the autorefractor, high K values greater than 47 diopters, progressive myopia, progressive astigmatism, asymmetry between the eyes, especially in patients in their teens, 20s, and 30s. Interestingly, this can be a very asymmetric disease, and in 5% of patients can present with completely normal curvature maps in the initially unaffected eye. However, over time, 50% of these initially normal eyes will go on to develop keratoconus. Therefore, it's extremely important to keep a close eye on that eye to catch and stop changes with cross-linking as early as possible. It's also important to get a complete history in these patients to know when they are at increased risk. So a history of allergies, eczema, eye rubbing, sleeping on the face is well documented to increase these patients' risk. History of laser vision correction, history of keratoconus in a first-degree relative offers a 15 to 67 times increased risk. Family history of corneal transplant, connective tissue diseases such as Marfan syndrome, Ehlers-Danlos syndrome, mitral valve prolapse has an association, and known genetic associations with Down syndrome, Turner syndrome, and osteogenesis imperfecta. When evaluating patients in your clinic, it can be helpful to take a quick look at the red reflex using direct ophthalmoscopy. Represented here is what you may see on an advanced keratoconic called the oil droplet sign, showing the distortion of the red reflex there centrally in the conic cornea. Scissoring on retinoscopy may be visualized when two band reflexes appear, which move toward and away from each other like blades of scissors. Most of the time, this occurs only in one meridian, and it's seen in keratoconus and also in irregular astigmatism. We only start to see findings of the slit lamp in keratoconus in moderate to severe disease, as it is common in early disease for slit lamp exam to be normal. One of the earliest findings you may see is a Fleischer ring or an iron deposition at the base of the cone within the epithelium seen in the top left photo here, along with subepithelial scarring. This can be further highlighted with a cobalt blue filter, such as the bottom left photo. The right photo represents Vogt striae, which are vertical whitish lines in the posterior stroma due to tension, and they will interestingly disappear with very light compression next to them on the cornea. Finally, the most advanced signs include Munson's sign, which is a V-shaped indentation observed in the lower eyelid when patients gaze downwards, Rizzuti sign, which is a triangular light reflection created with side illumination, subepithelial scarring, and acute hydrops when fluid rushes into the cornea from an acute break in Descemet's membrane. In the 1980s, the placido disc-based corneal topography devices were introduced. This represented an exciting advancement that could lead to diagnosing the condition before clinical signs were appreciated at the slit lamp. The projected concentric rings are referred to as mires, and the shape of the corneal surface can be inferred by inspection of these mires. Similar to a topographical map of a mountain, areas where the mires appear closer together correspond to steeper corneal curvature, and areas where the mires are more widely spaced appear flatter. These mires can also give information regarding the quality of the surface. Distinct well-formed mires are referred to as crisp and suggest the underlying corneal surface to be regular and smooth. As an ideal sphere, the cornea should have mires equally spaced over its entire surface, as pictured here in figure A in the top left corner. These mires are crisp and very round, representative of a good quality tear film surface with minimal astigmatism. In figure B in the top right corner, this represents distorted or wavy mires, suggesting surface tear film air interface irregularities such as those caused by dryness. Figure C in the bottom left corner shows regular astigmatism that elongates or pulls the mires into an ovoid shape opposite the axis of plus cylinder astigmatism, represented by the red line. This patient has high regular against the rule astigmatism after a full thickness transplant. In this case, sutures could be removed in this patient at 9 and 3 o'clock to attempt to reduce the astigmatism. Figure D represents irregular astigmatism with an irregularly distorted reflection of the mires in a post-full thickness transplant patient. One of the most commonly used topographers is the Atlas topographer, and I'm going to briefly review a few of the available reports, including a placido disc image for an initial assessment of the ocular surface. The Atlas can highlight patterns of astigmatism and tell you on a percentage basis how likely this pattern represents a diagnosis, such as in this patient, the pattern is highlighted as 85% keratoconus with an irregular astigmatism and a crab claw type pattern you can see on the axial curvature map with inferior steepening. The most traditional way to view a topography image is with the axial display map. One positive of this map is it's the best way to get a quick overview of the corneal power. It also, however, can be misleading because it averages the data to create a smooth map, making it less accurate than other power maps and most likely to hide subtle abnormalities. The tangential display map is the most sensitive way of characterizing the corneal curvature, but appears more noisy and more irregular. These maps measure power and curvature at individual points on the cornea and therefore are the most accurate. Finally, the elevation map display is the go-to option for conveying the true shape of the cornea. It is important to note that the placido disc systems use complicated algorithms to calculate the corneal elevation and only measuring the anterior corneal surface, while the Schleimflug systems, such as the Pentacam, measure the elevation directly by measuring both the anterior and posterior surfaces directly. Regardless, both systems output elevation in reference to a best fit sphere, which is calculated and extrapolated through the cornea. The systems then calculate areas of relative elevation or depression based on the deviation of the cornea from this best fit sphere. This photo shows topographical patterns that can be consistent with keratoconus. Classically, we think of H, represented here as asymmetric inferior steepening, but keratoconus can also represent as G, which are skewed radial axes of astigmatism, and J, which is a combination of both asymmetric steepening and skewed radial axes, or even more rarely I, which shows asymmetric superior steepening that can also be present. Here are some real-life examples of patterns you might see that are consistent with corneal ectasia. This shows a pattern of superior steepening in the left eye and inferior steepening in the right eye. This map shows skewing of the radial axes with asymmetric inferior steepening of both eyes, a very classic pattern. So you might be thinking to yourself, well, all of this topography information is all good and well if you have access to a topographer. If not, this is one good program to be aware of if you're interested in changing that. Glaukos, the current owner of the Avedro cross-linking system, has partnered with Topcon to offer a topographer a significant discount from the regular price. Information on this topographer is available at the Topcon website. And please note that I have no financial incentive to share this information with you other than hoping for earlier identification of cross-linking candidates. Again, if you're concerned about a patient but don't have access to a topographer, we're happy to see the patient for a pentacam topography and interpretation of the testing. You would just need to refer the patient using the specific language, and this allows us to perform and interpret the testing without a doctor's visit. If the topography is abnormal, the patient would then be scheduled with myself or Dr. Cam for a cross-linking evaluation, and this can currently be done at our Kansas City, Lee Summit, and Lansing locations. When patients come in for corneal imaging or a cross-linking evaluation at our clinic, they are going to get a tomography scan with the gold standard Pentacam device. This device uses rotating off-axis light to capture precise measurements of the anterior and posterior surfaces of the cornea, allowing the system to calculate global pachymetry as well as anterior and posterior surface data. This machine allows us to stage and follow keratoconus patients in ways we've never been able to do so before. The Amsler-Krummas classification was the earliest and most utilized system, but is now considered historical with inherent limitations, including using the central corneal thickness and central corneal anterior curvature. As we now know, early thinning and steepening are often on the inferior cornea, therefore missing early disease. Next came the modified Rabinowitz-McDaniel indices, and these again utilize a central keratometric reading greater than 47.2 considered abnormal, and inferior superior dioptric asymmetry with greater than 1.2 being suggestive of keratoconus. Both of these systems were based on placido disc anterior corneal imaging or topography and therefore likely missing early disease. Next, we'll be reviewing the most up-to-date tools for screening patients, the BAD display and the ABCD grading system. First, we will review the components of the BAD display. There's obviously a lot of information on this page, and so I'm going to really just try to hit the highlights for you. The Berlin-Ambrosio Enhanced Ectasia Display, or BAD display, is a screening tool used to identify patients at increased risk of developing post-laser vision corneal ectasia, therefore poor candidates for laser vision correction. There are many guidelines now in the literature that have been recommended to identify patients at risk, but abnormal topography is classically considered the most important. Routine screening prior to myopic refractive surgery is estimated to detect 1 to 6% of all keratoconus cases, which would otherwise be subclinical. The BAD is a comprehensive display which enables a global view of the tomographic structure of the cornea through a combination of elevation and pachymetric data. The data reports 5 differential parameters individually that denote the standard deviation from the mean normative database. These include changes in the anterior elevation, posterior elevation, the pachymetric progression, the thinnest value, and the vertical displacement of the thinnest point in relation to the apex. Each parameter is indicated in yellow, meaning suspicious, when it's greater than or equal to 1.6 standard deviations from the mean. It turns red at greater than or equal to 2.6 standard deviations from the mean, and values below 1.6 standard deviations are reported in white and viewed within the normal range. The final D is then calculated by considering all 5 parameters and performing a linear regression analysis against a standard database of normal and keratoconic corneas, and is considered to be the most important parameter. Based on studies involving eyes with very asymmetric keratoconus, a bad D value of more than 1.5 represents the most accurate risk factor parameter for detecting mild cases of ectasia or susceptibility. The purpose of this display is to screen normals from abnormal corneas, but not to diagnose keratoconus. And as of note, this display will look abnormal in all post-refractive corneas. The corneal maps on the left side of the display are computer generated, as raw elevation data really lacks sufficient surface changes to be viewed clinically and determine a difference between normal and ectatic corneas. The top map is the best fit sphere from the central 8mm optical zone on the anterior and posterior corneas. This display of the relative elevation of the cornea as compared to the best fit sphere helps mask the normal corneal asphericity or elevation. The middle 2 maps are enhanced elevation maps, which display the same data as the baseline, but the method used to calculate the best fit sphere has been modified to accentuate ectatic or conical regions, as represented in the cartoons on the right of your screen. In these maps, the central 3 to 4mm optical zone, centered at the thinnest point of the cone, has been eliminated, and this is known as the exclusion zone. By doing so, the new reference surface is calculated based on the peripheral normal corneal values. Therefore, any abnormal corneal protrusion will be especially highlighted as pathological. Lastly, the bottom maps show the relative change between using the standard and the new enhanced best fit sphere. This will be significant for conical corneas, while the difference is minimal in a normal cornea. The bottom map contains only 3 colors, with green representing differences seen on normal corneas, red differences on conical corneas, and yellow somewhere in between. Here you can see the same map on a normal appearing cornea where no data has been flagged or highlighted. This patient would likely be a good candidate for laser vision correction, pending an otherwise normal evaluation. The right portion of the map includes a lot of data that is beyond the scope of this talk. The most helpful information really comes from the 2 linear graphs at the bottom of the screen. These are the corneal thickness spatial profile, or the CTSP, and the percentage thickness increase, or the PTI. The CTSP displays the average thickness measurements along 22 concentric circles, and then graphically represents the progressive thickening of the cornea from the thinnest point more central to the periphery along these rings. The percentage of increase in thickness from the thinnest point to the periphery is depicted in the lower map by the PTI, or the percentage thickness index. They both display a central line as the average derived from a normal population, and then 95% confidence intervals are denoted by upper and lower black lines. The patient's measured corneal data is denoted in red, and ectatic corneas show a more rapid and more abnormal progression, as you can see on the right display versus the left. The last notable number on this display is the ambrosia relative thickness, or the ART max. This is a complex calculation ratio between the thinnest point and the PTI. This is considered a validated diagnostic index that distinguishes keratoconic and normal eyes. The cutoff value for the diagnosis of keratoconus is less than 412 microns. This slide reiterates the limitations of the anterior corneal data and highlights the importance of the bad display. In each section of this slide, the patient maps on the left represent pre-operative data, and on the right, post-operative data following laser vision correction. On the right section, the top map in this row shows you an axial map representing anterior corneal data with very small skewing of the radial axis of astigmatism, but this could easily be considered a normal map. However, when we take into account the bottom map in this row showing some mild posterior steepening, the top graph showing a rapidly progressive pachymetric index, as well as an elevated BAD-D and an elevated ART-MAX score, this patient likely should have never had laser vision correction. And not surprisingly, the postoperative map 2 years later shows frank ectasia that this patient went on to develop. Alternatively, moving on to the right section of the slide, the top map in this row again shows you an axial map representing anterior corneal data with frank asymmetric inferior steepening. If only considering this anterior data, we would be concerned that this represented ectasia in this patient. However, when looking at the normal posterior best fit sphere in the bottom map in this row, and then the normal pachymetric progression graph at the top, as well as normal BAD-D score and a normal ART-MAX, we should rest easier this patient is at low risk. The postoperative maps represent this patient's data at 4 years are without any concerning findings for ectasia. The pachymetric progression maps are particularly helpful when trying to determine if a thin cornea is ectatic or just a variation on the spectrum of normal. Both of these patients have thinner than average corneal pachymetry at the apex of less than 500 microns. The patient on the left has a very normal appearing pachymetric progression, and therefore this is likely just a variation of normal. However, the patient on the right has a rapidly declining pachymetry progression, and this is likely representing ectasia. Lastly, we will be discussing the utility of the Berlin ABCD grading system. This grading system comes from the topometric keratoconus staging display, and it incorporates many of the old staging indices from the anterior data that are highlighted in purple, as well as the newest staging criteria, the ABCD grading scale that incorporates newer posterior corneal data, as well as pachymetric data, which is highlighted in blue. The two most noteworthy indices within the purple box are the index of vertical asymmetry, the IVA, and the index of height decentration, or the IHD. The IVA is the mean difference between the superior and inferior corneal curvature, and greater than 3.2 is pathologic. It's highly sensitive in differentiating keratoconic and normal eyes, and highly specific for prekeratoconic corneas. It's been considered second to the BAD-D in terms of accuracy of predicting keratoconus. Secondly, the IHD measures the vertical decentration of elevation data calculated by using a Fourier analysis on a ring with a radius of 3 millimeters. An IHD of greater than 0.016 is pathological, and it's thought to have the potential to discriminate prekeratoconic cases. Moving on to the ABCD system, which uses 4 parameters: A, which is the anterior radius of curvature from a 3 millimeter optical zone centered on the thinnest point; B, which is the same but on the posterior radius of curvature; C, which is the minimal corneal thickness; and D, user and entered best spectacle corrected vision. The keratoconus is then staged 0 to 4. And you can see the staging reported at the very bottom here, representing A2, B4+, C1, and D2. These grades are then plotted on the progression display and can be monitored with each new scan, as we see here. The progression display really offers the ability to be a game changer of documenting progression at its earliest stages, and therefore preserving as much vision as possible in potential keratoconics. This display allows us to plot up to 8 examinations over time, graphically representing each ABCD parameter. These are gated with one-sided confidence intervals at both 80 and 95%, and the confidence intervals for both a normal population are represented in green and keratoconic population in red. The hope is by using the confidence intervals, we kind of rule out measurement noise. The normal base gates are suggested for young patients with early disease, whereas the keratoconic gates are meant for the most established cases. The most recent iteration of the display also allows confidence intervals for cross-link treated eyes. This data is only applicable after a minimal healing time of 12 months. The cross-linking treatment date can be entered, and then these will display in blue automatically starting 12 months later. In a series of patients who met the often insurance required 1 diopter progressive steepening of K max for cross-linking, a historical review of their tomographic records showed that more than half of the patients could have been identified on average 5 months earlier using the ABCD progression display. The hope is that this system will allow for earlier intervention to prevent visual loss, not just stabilizing the visual loss once it's already occurred. In this display represented here, we see an early keratoconus patient followed for 8 months who showed a stable K max over this time period. Despite his stable Kmax, both of the posterior readings, B and C, showed high significant progression, falling far in advance of the 95% confidence interval for a normal population in green. This is very concerning for progression, and the patient deserves cross-linking, in my opinion, even though he still falls outside of most insurance standards. When these patients need a topography, the question often comes up, how long do they need to be out of their contact lenses? Unfortunately, there's really no great data here to my knowledge, but if someone has better knowledge than me, please educate me. We think that RGP wear and even conventional soft contact lenses will alter data more than sclerals. However, there is one paper published in 2015 that reported the use of sclerals can alter Kmax data by more than a diopter. The ideal discontinuation time prior to topography measurements really has not been well established, and it's especially difficult in these keratoconic patients due to their heavy reliance on their contact lenses for decent vision. If able to tolerate glasses, I ask them to be out of their contacts for 3 days. If unable to tolerate glasses, we ask for 24 hours, and patient compliance is understandably difficult. So who is a good candidate for cross-linking based on the FDA guidelines? Ages 14 to 65, diagnosis of keratoconus or ectasia after laser vision correction with progressive myopia and or astigmatism, greater than 47 diopter Kmax with progressive steepening, epichrometry greater than 375 with the epithelium on, progressive thinning, a less than 20/25 best corrected visual acuity and vision that's correctable in glasses or a contact lens. Patients with the following findings are typically excluded: pachymetry less than 375, pregnant or nursing, marked corneal scarring, prior corneal surgery other than LASIK or PRK, unsteady gaze, prior herpetic infection, severe ocular disease, neurotrophic patients, and autoimmune disease. With the 2006 FDA labeled indications in the United States, the cross-linking system can be considered for off-label use with special informed consent. Some of the considerations for special situations include poor candidates for transplant, such as those with Down syndrome. And these patients, unfortunately, frequently present with very advanced keratoconus and thickness less than 375. In this situation, we may consider contact lens assisted cross-linking, and this can be performed with a contact lens soaked in riboflavin to add a layer of protection from deeper penetration of UV light. It is, of course, imperative to make sure the contact lens does not have UV protection within it. Some prominent doctors in the field have also advocated that there may be a benefit to stabilizing the future graft-host junction in severe keratoconic patients with cross-linking, even if you think there's a good chance they may end up needing a future transplant. Transplant surgery, as we know, does not cure keratoconus, and we not uncommonly can see it recur at the host edge of the graft. The hope is that this could prevent that. A recent study found topographic, pachymetric, and biomechanical evidence of keratoconus progression in 100% of its pregnant patient cohort. This led researchers to recommend discussing prophylactic cross-linking with female patients prior to family planning. Some European countries have begun to prophylactically offer cross-linking to female keratoconus patients who are planning for pregnancy despite lack of disease progression. Many US doctors are now counseling their patients on this possibility as well. However, in the US, the insurance does limit our ability to offer this potential service to patients unless they have the ability to pay out of pocket for the treatment. Keratoconus in children, as we know, typically starts at puberty. However, the youngest patient reported was just 4 years old. Children tend to progress more rapidly compared to adults, and they're therefore frequently more severely affected at the time of diagnosis. They tend to show a central cone pattern rather than the commonly peripherally seen cone, so we may not see asymmetric inferior steepening as classically described. We know this is associated with allergic disease such as vernal keratoconjunctivitis, allergic keratoconjunctivitis, and atopic disease with eye rubbing. We also know that there's 6 to 57 times increased risk in first-degree relatives, and I would really recommend screening anyone who falls into these categories. Cross-linking is a first-line treatment for these patients, as corneal transplant remains very risky in these age groups with higher rejection rates and poor visual outcomes. Cross-linking in these patients can often require OR time with IV sedation or even general anesthesia, and this is off-label and does require special consideration and consent. Just to reiterate how quickly these young patients can progress, this study from the JRS in 2021 highlighted the risk of progression in patients who were delayed treatment due to COVID restrictions for a mean wait time of 85 days. During their wait, 25% had progressed, with a progression group having a statistically significant younger age than the non-progressive group. At the opposite end of the spectrum, we do still have to think about progression in our older patients as well. However, true keratoconics tend to display a slower rate of progression or even stabilization in the 4th or 5th decade, and this is thought to be a byproduct of age-associated cross-linking. This is not true, however, of all keratoconics, as defined by a retrospective chart review from the Wills Eye Hospital that found 24% of 186 eyes newly diagnosed with keratoconus belong to patients 40 or older. In addition, given that post-surgical ectasia can occur at a later point in life than typical keratoconus, clinical consensus has not defined an age range for when ectasia typically occurs and when progression may slow down in that group. Lastly, this is especially not true in pellucid marginal degeneration pattern patients, which is likely a variation of keratoconus and is known to start at a later age. Interestingly, in my practice, I see a mother with pellucid diagnosed in her late 40s and a daughter diagnosed just a few years later with keratoconus in her early 20s. One interesting off-label group to consider are post-RK patients experiencing visual fluctuation. As we all know too well, two of the significant and troublesome complications of RK are progressive hyperopic drift of refraction and diurnal fluctuations of vision caused by variations in corneal hydration and intraocular pressure throughout the day. This Canadian study focused on 9 eyes and 6 patients on the outcomes of corneal cross-linking for RK-operated patients experiencing corneal instability, reflected as decreasing vision and/or diurnal fluctuations in vision. Cross-linking was performed per the Dresden protocol, and 8 of 9 eyes discontinuation of diurnal fluctuations was noted at 6 and 12 months post-operatively. However, not unpredictably, patients experienced reduction or flattening in the mean keratometry readings with resultant further hyperopic shifting of the refraction, on average 1 diopter with plus or minus 2.5 diopters. Therefore, if considering this, patients really should be counseled on the expected outcome with a plan for restoration of vision following the procedure, either with glasses, contact lens, or even consideration for a refractive lens exchange that would need to be 1 year or longer from the cross-linking procedure. Of note, one patient did have wait front guided PRK 6 months following cross-linking, and diurnal fluctuations returned and were not alleviated by a second round of cross-linking. Results of this study are limited by a lack of long-term follow-up, as the study only went out to 12 months. These off-label treatments, however, do come with very real risks, such as in this case reported of a 28-year-old known keratoconus patient who was treated in Turkey with 8-cut RK, and the patient then developed continued corneal thinning down to 382 microns with a Kmax of 52. 8 months after the treatment, the patient exhibited frank worsening of her ectasia with a Kmax of 57 and associated 3-line drop in her best corrected vision and splaying of 2 of the 8 RK incisions. Not ideal. Moving on to the topic of what defines progression of keratoconus, which unfortunately continues to be a controversial subject, especially between doctors and insurance companies. The 2015 Global Consensus on Keratoconus and Ectatic Disease was a seminal paper and product of the 4 major multinational cornea societies, and stated that there is a lack of any clear and clinically appropriate definition of ectasia progression. They encouraged focus on the abnormal posterior cornea and abnormal pachymetric progression. There was a seemingly purposeful lack of inclusion of Kmax or loss of best corrected visual acuity in what was considered findings of progression. This focus on early and subclinical posterior and pachymetric findings are a shift in the mindset of treating keratoconus in a preventative fashion rather than waiting for irreversible vision loss to occur. Currently in the US, we are limited to treating progressive disease as defined by insurance standards unless the patient has the ability to pay for the treatment out of pocket themselves. These standards are unfortunately still based on anterior corneal and refractive changes that more often lead to loss of vision while we're waiting to prove progression. As newer methods of cross-linking emerge and the posterior corneal changes that occur are better documented, the goal of treatment really should be prevention of disease, not just limiting the damage once it has occurred. The standards that are required by most insurance companies include the following, and typically 2 or more are required. Half a diopter increase in manifest spherical equivalent of myopia, 1 diopter or more increase in manifest cylinder, worsening of best corrected visual acuity, steepening of the Kmax 1 diopter or greater, Kmax of 47 diopters or more, progressive thinning of 10 to 15 microns of the thinnest pachymetry, and is typically required to see these changes over 12 months. We typically will request 2 years or beyond of previous data, including previous and current refractions, best corrected vision in glasses or contact lenses, previous or current keratometry, and if you happen to have a pachymetry or a topography, that's extra helpful too. When you're seeing patients with any potential keratoconus risk, it's very helpful if you can record keratometry or even autokeratometry, as this is frequent where we're going to go back on to prove progression, especially when we need to meet that 2 criteria data. Unfortunately, when we see patients, even if it's pretty obvious to us they're progressing by history with a prominent cone on topography, we don't have sufficient data to prove progression. We must follow these patients in our office every 3 to 6 months until we're able to meet the insurance standards to crosslink. We've created a 1-page reference form to help you recall what the cutoffs are for concern on patient workup that might prompt you to consider getting a topography in your clinic or sending the patient over for a topography test and interpretation with myself or Dr. Kiam. And again, this can be done without setting up a doctor's visit. If we see an abnormal change, we will set the patient up for a cross-linking evaluation. This form is available on our website, and Whitney will have some with her when she's out visiting your offices. Briefly, to review the cross-linking procedure we perform the cross-linking under the FDA-approved Dresden protocol, and we apply anesthetic and remove the central 9 millimeters of the corneal epithelium. The topical anesthetic is applied, followed by Photrexa viscous for 30 minutes, and confirmation is performed by AC flare. We then check the central corneal thickness to make sure that we're greater than 400 microns, and then we can move on to the next portion of the procedure. The cross-linking unit is then brought into position by the UVA exposure for a total of 30 minutes for a total energy dose of 5.4 joules per centimeter. Riboflavin is then applied for the duration. And occasionally I have had patients ask about the risk of UV damage to the untreated portions of the eye. And thankfully at this point, that is something we just have not seen. In fact, a riboflavin saturated cornea is at least 400 microns in thickness, and the UV irradiance transmitted to the endothelium is only 0.18, whereas the actual endothelial damage threshold is 0.35. Therefore, the energy level projected to reach the crystalline lens and the retina is even lower compared to the respective damage thresholds for these tissues. Postoperatively, just like PRK patients, these patients will be uncomfortable for the first 24 to 48 hours. And interestingly, through pain, they really tend to experience more rapid epithelial closure and more rapid improvement of their pain. We do expect them to be uncomfortable with tearing, light sensitive, and blurry vision due to the epithelial defect. A bandaged contact lens is placed, followed by topical antibiotics until we see epithelial closure, usually at day 4 to 7. They're instructed, of course, on activity precautions, especially to avoid eye rubbing. And we do tend to continue a topical steroid to modulate expected haze for 2 months after the procedure. We instruct them not to wear their habitual contact lenses while healing and to call immediately for signs and symptoms of problems. Commonly, when you see these patients postoperatively, you will see haze, and this tends to be the most prominent at 1 month. And at this visit, if I see more expected haze, I may increase the frequency or duration of the steroids to modulate it. If you look with a bright, thin slit beam, you will see a demarcation line of treatment into the mid-deep stroma. As the haze is resolving, patients may complain of gaze of glare and hazy vision. And as the keratocytes slowly repopulate, the backscattering of light starts to resolve and the areas of cross-linking haze begin to fade 3 to 6 months later. The haze will often become unnoticeable by 1 year post-cross-linking. When patients return at 1 month, I expect their topography to look steeper or worse, and everyone has this haze. Any flattening that's going to occur then happens rapidly, with many patients returning to their baseline keratometry by 3 months and further flattening seen out to 1 year. Most patients have stabilized around 12 months, and this is considered their new baseline. A smaller percentage will still have some changes out to 24 months. I will typically return the patients to your office for contact lens fitting at 6 to 8 weeks postoperatively. If they prefer to stay in their glasses, we may wait until 3 months or longer to assess the vision of their baseline keratometry to determine the need for an update. All of the patients are warned about the need to update glasses and contact lenses more frequently than usual after the procedure. After that first update, most patients will want to wait to update again until about the 1 year mark, as that's considered their new baseline. Post-operatively, I like to follow these patients at 3, 6, and 12 months, and then annually with a pentacam thereafter that. This allows us to monitor for the expected changes following the procedure, and then with a new baseline topography noted at 12 months and monitoring for progression annually after that. If any progression is noted beyond 12 months, additional treatment may be considered, and I expect the patients will stay with you during this time as well to follow up with their refractive demands. When referring these patients, you may need to discuss the refractive goals of the procedure, and I review this with them too, of course, which is to increase the rigidity of the cornea and decrease the clinical progression of ectasia, not unfortunately to eliminate or reverse any existing ectasia. Cross-linking is not intended to eliminate or reduce dependence on refractive correction. Therefore, we expect these patients to maintain their current level of refractive demands, whether they're currently in glasses, rigid contact lenses, or sclerals. When referring patients over for the procedure, I would recommend encouraging them to hold on ordering new contacts or glasses, because if we treat them, this will be very wrong postoperatively. Although not the goal of the procedure, we do see some quote unquote normalization of the corneal shape in some of these patients, and it's thought that this is responsible for the subjective reports patients give an improvement in their vision and improvements that are seen in their best corrected vision. If you examine the topography in these patients post-op, you will see what has been called post-cross-linking normalization, where their steeper back part of the cornea flattens and the flatter part of the cornea steepens. This is essentially the reverse of what you see in cross-linking progression. And you can see this represented here with the post-cross-linking map on the far left, the pre in the middle, and the difference map on the far right 4 years after treatment. In the US cross-linking trial, they saw on average 1.6 diopters of flattening at 12 months, a 5.7 letter average improvement in corrected vision, and a 23% gain 2 lines of vision. Patients reported subjective improvements in night driving, difficulty reading, diplopia, glare, fluctuation of vision, and foreign body sensation. And most importantly, the trial was 94% effective in preventing progressive ectasia. Additional benefits of cross-linking include societal and economic benefits of reducing the rates of corneal transplantation. In Norway and the Netherlands, they found a 25% decrease in PKP at 6 and 3 years respectively after cross-linking was introduced. Thankfully, insurance coverage for progressive ectasia patients has improved once they meet the required standards, with over 96% of payers covering the procedure at this time. If you have an uninsured patient that is able to document financial need, Glaukos will reduce or cover the cost of the riboflavin, and we will mirror that reduction in our fees to get these patients taken care of. If you have further questions, please feel free to reach out to myself or Dr. Cam. Additionally, there are educational materials on our website, both for you and your patients. And again, you can find our reference documents and our referral forms there as well. And in summary, cross-linking provides a new hope in a progressive degenerative disease. Optometrists play a critical role in the early diagnosis and education of the patients regarding the benefits of cross-linking, and early treatment is really imperative to maintaining good vision and avoiding transplant in these patients. Thank you all for spending your evening with us. I think when I was here 2 years ago, I got to share pictures of my 3-month-old Charles, and then now this is my almost 2.5-year-old Charles that very kindly shared his cold with me. So I will stick around here for questions and check the chat. And if any of you have questions, feel free to speak up as well. Thank you. All right. If you are 20/20 OD, OS, OU, and your character outdrains are greater than 48 vertically with minimal asymmetric and absolute months and sign upon down gaze, when should you consider seeking the introduction of cortical topography to evaluate thinning? So answering Dr. Godshall's question, I would definitely not wait for symptoms in that situation. By the time you have symptoms, I would be concerned for progression. So really wanting to catch these patients as early as possible in monitoring for progressive disease. By the time you have symptoms, you're really expecting to see anterior disease. And by that time, patients are losing vision. And so keeping these patients, diagnosing them as early as possible and cross-linking them as early as possible is the key. So Lauren asked, cross-linking under 18, do you still recommend sending to CMH? In general, I will see patients 16 and up. These patients often do require some more anesthesia. And so some of it is dependent on the patient's ability to participate. But I am in general happy to see patients 16 and up. If you have specific patient questions, feel free to reach out, text me, call me, and I'm happy to talk through that with you too. All right. Well, not really seeing any additional questions pop up, not hearing anybody speak up. So thank you again, everyone, for joining us tonight. And again, we hope to be able to see it in person for the next one. Have a good evening.
Hey, Bruce.